Welcome to today's Explainer. We're jumping right into the complex and honestly fascinating pharmacology of depression. We're going to look at all of this through the lens of a massive medical trade-off. It's basically a balancing act between getting maximum relief and managing some pretty serious adverse side effects.
So let's kick things off with a genuinely encouraging statistic from the literature. Roughly 80%, or honestly, even more, of patients are going to respond to at least one of the antidepressant drugs we're exploring today. That's huge. But the real challenge for medicine hasn't just been finding something that works. It's about finding something patients can actually tolerate in their day-to-day lives. Here's our quick roadmap for today. 1. The brain's chemistry. 2. SSRIs, the modern standard. 3. SNRIs for dual-action alternatives. 4. TCAs, those older, sharper tools. 5. MAOIs, the last resort. And 6. Finding the right fit. Section 1. The brain's chemistry. To really get this, we have to look at what's called the biogenic amine theory. Most clinically useful antidepressants act on this exact premise. The basic idea here is that depression stems from a deficiency of vital monoamines, specifically norepinephrine and serotonin, right there in the brain. So by directly or indirectly targeting these pathways, these medications are basically trying to boost the concentration of those essential chemicals in your brain's synapses.
Now, this is where things get wild. Look at this timeline. A really mysterious paradox emerges here. These drugs block reuptake and alter your brain's chemistry almost immediately, literally on day one. And yet, it takes a minimum of 2 weeks to see any real improvement in mood. And maximum therapeutic benefit? Well, that can take up to 12 weeks or more. It's a massive paradox, and we are absolutely coming back to it later.
Section 2. SSRIs, the modern standard. You've probably heard of these. Drugs like fluoxetine and sertraline. They act like a highly targeted blockade in your brain. Get this, they have a 300 to 3,000-fold greater selectivity for the serotonin transporter compared to the norepinephrine transporter. Basically, they specifically block the reuptake of serotonin. That means way more of it just hangs out in the synaptic cleft to elevate your mood, without messing too much with other systems.
They're the standard drug of choice today, mainly because they are incredibly safe. Unlike a lot of older drugs, they are relatively safe even if someone overdoses, and they don't have those severe cardiovascular side effects. But there is a trade-off. Patients might deal with gastrointestinal issues, sleep disturbances, like insomnia or just feeling super sleepy, and sexual dysfunction. Plus, if you just stop taking them abruptly, you can get hit with a pretty nasty flu-like discontinuation syndrome.
Section 3. SNRIs, dual-action alternatives. So while SSRIs are super focused on serotonin, SNRIs, which stands for serotonin and norepinephrine reuptake inhibitors, are dual action. Drugs like venlafaxine inhibit the reuptake of both serotonin and norepinephrine. This is a total game changer for patients who just don't respond to standard SSRIs. It casts a slightly wider chemical net. What's really fascinating here is a sort of built-in secondary benefit. Physical pain is actually modulated by these exact same central nervous system pathways. Because of that, SSRIs are incredibly useful if you're treating depression that's accompanied by chronic pain, things like diabetic neuropathy or a chronic backache. The trade-off? Well, alongside GI and sleep side effects that are pretty similar to SSRIs, they can also bump up your blood pressure and a heart rate if the dose gets high enough. Section 4. TCAs. Older, sharper tools.
Now we're stepping back in time a bit. While TCAs share that same dual action mechanism as SNRIs, meaning they block both serotonin and norepinephrine reuptake, they are nowhere near as precise. They clumsily bind to and block a bunch of other receptors in your body too, specifically muscarinic, histaminic, and alpha-adrenergic receptors. And as you might guess, that leads to some widespread and pretty severe consequences across multiple bodily systems.
Now, TCAs do their main job really well. They elevate mood in about 50 to 70% of people with major depression. But because they hit so many other systems, you're looking at intense dry mouth, blurred vision, and dizziness when you stand up. And here is the most dangerous part. They have a really narrow therapeutic index. Taking just 5 to 6 times the normal daily dose can cause life-threatening cardiac arrhythmias. That massive overdose risk is exactly why SSRIs largely replace them.
Section 5. MAOIs, the last resort.
To understand these, think of the enzyme monoamine oxidase as your brain's cellular vacuum cleaner, constantly sweeping away excess neurotransmitters in the neuron. Well, MAOIs act as blockers that irreversibly shut that vacuum down. Since the safety valve is closed, neurotransmitters like dopamine, serotonin, and norepinephrine just accumulate and completely flood the synaptic space.
These are remarkably effective for certain types of depression, especially atypical depression. But the trade-off here is absolutely massive because of drug and food interactions. Patients have to completely avoid tyramine-rich foods. I'm talking aged cheese, red wine, smoked meats. Without that MAO enzyme in your gut to break the tyramine down, eating just a simple piece of aged cheese can trigger this massive release of catecholamines, leading to a potentially fatal hypertensive crisis. Because of that strict diet and the risk of severe interactions, MAOIs are strictly considered last-line agents.
Section 6. Finding the right fit. So the big takeaway here is this: newer drugs aren't actually more effective at elevating your mood than the older ones. Those older TCAs and MAOIs are incredibly potent. But when you map it all out side by side, the modern standards like SSRIs and SNRIs are just vastly safer and so much easier for patients to actually tolerate every single day. The whole evolution of these drugs has basically been a massive pursuit of selectivity, trying to get the exact chemical change you need without accidentally blowing up the rest of the nervous system.
Before we wrap up this explainer, I want to leave you with a really provocative thought straight from the research. Remember that timeline we talked about earlier? If these medications physically alter neurotransmitter levels in your brain on day 1, but it takes up to 12 weeks to actually feel relief, well, that suggests that just lacking serotonin isn't the whole story. Decreasing reuptake might just be the initial spark. So, what deeper structural healing is the brain actually undergoing during those 12 weeks? What hidden frontier of neuroscience are we still waiting to discover? Keep that in mind the next time someone brings up brain chemistry.